And in the meantime, I'll start with the next session on advances in heart failure. And I'll be inviting the chairperson, Dr. Mrinal Kanti Das from Kolkata CK Birla Institute, and to be on the stage. I'll request my panelists to please join us on the stage. Dr. M.D. Gupta, who is the ex-HOD of Hindu Rao Hospital, Dr. Ashok Garg from Jaipur, Dr. Ashish Saxena from Ludhiana, Dr. Vivek Kumar from Fortis Escorts, Delhi, Dr. T.M. Agrawal from Delhi, Dr. Smita is not there. Dr. Vivek Sulere has reached or not? So welcome all. Yeah. So we'll start with the first session, first case. You'll be inviting.
Okay. Just before we start the session, I would like to thank Dr. Rakesh Gupta for organizing this meeting and calling me to this conference. Really thankful to him. And second thing is, the subject or the session or the symposium whole thing is focusing on the cardiometabolic syndrome. And this is the session where it fits so well. That is the heart failure session where CKM or CRM fits very well. And the reason we are discussing about this topic because of the high association of mortality and morbidity in heart failure. It ranges from a few millions to 64 million in a year. And that too with the continuum of the various levels of heart failure, right from heart failure with preserved ejection fraction to mildly reduced to, the heart failure with reduced ejection fraction, and now it is improved ejection fraction. And all have got different connotations and very much correlation with the CKM. So with that note, I request Dr. Chopra to speak on CKM and other things related to CKM. Dr. Chopra, please.
And I'll request all the speakers and the moderator to kindly stick to the guns. Thank you.
Ladies and gentlemen, the talk given to me is CKM, obesity, HFpEF, and HFpEF is very well known to all of you. The prevalence is rising very steeply in the country. You already heard on 15th of August about Prime Minister. Obesity crisis should be known to each and every one of us. And my aim is to highlight the morbidity and mortality benefit of SGL2, GLP-1 receptor agonist, as well as semaglutide and tirzepatide. This is the definition of CKM, reflects metabolic risk factors in CKD and CVS with mortality. This is very well known to each and every one of you. Stage 1, when there is a adipose dysfunctional. Stage 2, risk factors. Stage 3 is subclinical, and stage 4 is CVD. This is what we see in all our day. Obesity is very well known to you, rising, very common in Punjab, Delhi, Tamil Nadu, and Kerala. See, this is what is happening. On one side is angioplasty, on one side mushrooming of McDonald. This is what's happening. The uncontrolled hypertension is rising, 90%, almost seen by Ministry of Health, ICMR, and WHO. Prevalence is more in women as compared to men. And we see the HFpEF phenotypically definition is very well known to you, more than 50%. And the prevalence is very, very common in women as compared to men, should also be known. This is the first data I published in 2007 in Indian Heart Journal. And there was a lot of reaction, where I mentioned central obesity is the most powerful predictor of CVD. In 2007, it took 18 years for people to understand and say it's true. We see here, females more common with HFpEF. See the pathophysiology showing everything. There is a little difference in obesity and hypertension. Hypertension is increased afterload and left ventricular hypertrophy and fibrosis, while in obesity, it is adipose tissue, systemic inflammation, and endothelial dysfunction. Ultimately, all give rise to HFpEF. And when the HFpEF is not controlled, it gives rise to HFrEF. So very important, we all should know leptin levels. All obese people have higher leptin levels, which are pro-inflammatory, pro-atherogenic, pro-fibrotic, pro-vascular stiffness, and causes all kinds of stress, mitochondrial, oxidative, as well as endoplasmic reticulum. And see the hemodynamic variables, ladies and gentlemen. We see the ventricular dysfunction, atrial dysfunction, autonomic dysfunction, and mitral dysfunction. Everything is visible. This is from Anchor obesity and hypertension are the very powerful predictors of HFpEF. And see the pathophysiology, stiff and remodel LV, LA, pulmonary artery, and pulmonary vasculature. And the same thing is mentioned here, that the neurohormonal activation is very, very important, and increased calcium signaling are important to give rise to HFpEF. This is what we see every day. Every possible artery is affected, and we give rise to CVD, heart failure, and diabetes. And we see here the outcome data, very clear by a CHARM study, as well as by paradigm study, increased mortality and increased heart failure. And see the data from Trivandrum heart failure study, very well known to all of you, increased mortality, increased readmission rate. And see the equation which we use, European as well as American. As you heard, both Rakesh and other people, E by prime ratio and the LA strain is very, very important. Similarly, NT-proBNP of more than 220 in sinus rhythm, and NT-proBNP of more than 660 in atrial fibrillation. American criteria is a little different, where they take BMI, hypertension, atrial fibrillation. This is what we do in our lab every day. And we see 90% of patients, which I see with hypertension and obesity, have HFpEF. Very alarming data and a matter of great concern. And we see here, all the parameters have been mentioned to you: increase LA size, increase LA volume, LV mass index, LAVI more than 34 ml per meter square is a very, very powerful predictor of atrial fibrillation, resistant atrial fibrillation even thromboembolic episodes. You heard. This is the arteriopathy mentioned by Scott Sullivan in stage 1, stage 2, stage 3, and stage 4 irreversible. You'll be surprised, ladies and gentlemen. A lot of patients who die in our hospital now are arteriopathy more than ventriculopathy. This is a very important message. LA stiffness is very, very important. Increased hospitalization and mortality. And even we see the LA fibrosis can be predicted by CMR. CMR plays a very, very important role. This is in short, reduction of LA strain. Rakesh has mentioned very nicely. Reservoir or conduit or even the LA booster strain, reduction is responsible for high mortality and morbidity. What's the treatment till 2019? No benefit by any studies mentioned here. And see the SGL2, reduce the MACE rate, hospitalization, the renal protection, very well known to all of you by all these studies. And we see the SOLO study showing the functional benefit. Emperor Preserved study has shown the composite primary endpoint and secondary endpoint benefit. And you see the Emperor data, very, very irrespective of gender, NT-proBNP benefits are shown in the landmark trial, and improvement in the decline of the GFR. And see the difference. Compare of Emperor with Imperial, Deliver, and Preserved heart failure trial have shown the mortality benefits are seen only with empagliflozin and not with RNA. The Deliver trial is also known to you. Primary composite endpoint, worsening of the heart failure, severe death, and all-cause mortality. All the benefits are seen with SGL2 irrespective of ejection fraction. See the guidelines. The data is very clear. Recommendation class is 1A. And the Eugene Broadwell Corner has mentioned the statin of 2021 is SGL2. And see the data now. In European heart study, 3 pillars of HFpEF. Number 1 is Ozempic. 2 is Mounjaro, which we use very commonly, the tirzepatide or semaglutide. That's the future. And this is the data published in circulation showing SGL2 and GLP-1 receptor agonists reduce the MACE rate, hospitalization, all-cause mortality, cardiac mortality, and even the CKD progression. This is a very important slide to show a comparison of empagliflozin is definitely superior, but we need more data as compared to DAPA because the glycosuria is more and the diabetes control is better and the symptom relief is early. Hospitalization and the worsening of heart failure is definitely better. All-cause mortality and severe deaths are also reduced. And the impact study, which by MI, have shown 10% risk reduction as compared to DAPA, where there is only cardiometabolic benefit. And see the data of STEP-HFpEF and STEP-HFpEF diabetes trial have shown semaglutide, which is used 2.4 milligram per week, 52 weeks, there are only body weight reduction and the risk score. Similarly shown here that NT-proBNP reduction and by KCC score is better. A very important slide to have a comparison of the two. Tirzepatide and semaglutide. We see here head-to-head trial. A1C reduction is better with tirzepatide as compared to semaglutide. And we also see the weight loss reduction is also better. The data has been shown by SURPASS, SUSTAIN, and STEP trial. This is a very important slide to show the comparison of Summit, Symphony, and Triumph trial that the Meta-analysis is very clear. MACE reduction, mortality reduction, and body weight reduction is superior with tirzepatide as compared to semaglutide. This is the game changer. This is just to show the AI-powered algorithm. HFpEF care must target upstream drivers. AI enables precision and timely therapy. We have published 3 books on heart failure, one on atrial fibrillation and one on hypertension. To conclude, ladies and gentlemen, health of millions is at stake in India with hypertension, CKM, and HFpEF. Clinico-Echo metabolic therapeutic navigation is very, very important for us to know. And we see here SGL2 and molecule like GLP-1 receptor agonist are the future and the present. Hit hard, hit safe, and hit early, and optimize the therapy very effectively in a protocolized manner. Robust data is available. My tribute to Anchor, Butler, Nassif, Bhatt, Abraham, Solomon, and McMurray. I think the answer is very clear. SGL2, GLP-1 receptor agonists, loop diuretics, and RNA are the future. And we must treat HFpEF not easily. Treat very seriously. CKM, obesity, and HFpEF, treat intelligence treatment. Cardiometabolic health is the total health, ladies and gentlemen. Blood flow in each vessel is 1 kilometers per hour. My message is very clear. The secret to living well and longer is eat half, walk double, laugh triple, and love unconditional. Thank you very much.
Excellent, Dr. Chopra. You have covered almost most of the things, and a big congratulations for this elaboration. Just to one point, rather 2 points which are very much closely associated with your whole topic. One is the obstructive sleep apnea, which is the central focus of discussion nowadays, and number 2 is the air pollution, which is again related to the obesity. So just 1 or 2 points regarding
I think
this.
it's very important. Obstructive sleep apnea is a very, very important cause of HFpEF. And when the HFpEF is there, it's a convergence, as the cardio convergence mentioned. From periphery to the center is HFpEF, and the divergence is HFrEF. So when we have obstructive sleep apnea, it's the convergence effect. As I mentioned to you, various mechanisms in pathophysiology all are activated, whether it's SNS activation or RAS activation, or even the mitochondrial oxidative stress is more in the obstructive stress, and that's how the HFpEF is there.
Thank you. Any comment from the panel?
When we come to the use of SGLT2 inhibitors, like we have got DAPA on one side and AMPA on one side, it is always a dilemma which to start in which condition. Can you just enlighten on that?
I think it's a very important question. The advantage of empagliflozin is 10 milligrams and 25 milligrams. And all diabetic patients, the response is superior as compared to DAPA, because we can titrate and there is a huge data to support what I'm saying. The second thing is, I've seen the meta-analysis from China, which is very clear, and they've shown that the metabolic effects and the mortality, especially the all-cause mortality, is reduced better in EMPA as compared to DAPA. The third point, which they mentioned, the diabetes control and glycosuria is more with EMPA as compared to DAPA. And last point, that the SGL2 inhibition is 2,500 times as compared to DAPA, which is 1,200 times. So pharmacologically, pharmacokinetically, clinically, and biologistic data, it favors empagliflozin.
Fantastic. I think let us go to the next topic. And before that, let us give a very big hand to Dr. Chopra for his beautiful presentation. Dr.